So here's the pancreatic transection margin. You'll notice that there's normal pancreas, normal pancreas. There's probably some duct in here. There's some fibrosis. And I'm trying to see under very low power if any of the glands are out of place. So I'm not really seeing anything atypical outside or between these lobules. But let's keep looking. So here you go. I'm essentially focused in and around these fibrous septae. Remember, this patient was treated with neoadjuvant therapy. There's a bunch of glands here, but they're falling apart and they look rather monotonous, don't they? Here you go again. A couple of more glands, a couple of more glands here. Um, Here you go. This area seem to be randomly scattered within this fibrous tissue, but when I look at them under higher power, I'm not convinced I can call it carcinoma. Perhaps you can, but I can't. Here you go. This is a good representation of all of those, that cluster of glands. And then there is this interesting area here. I think it's slightly out of focus, but that may be a duct. And then there's this interesting area here. Although if you look at these cells, they again look pretty bland. So I guess the question is, and I've essentially shown you everything there is to see. The question is this positive, negative, or atypical? So this turned out to be invasive adenocarcinoma at the transected margin. Here's the permanent section. Here's that duct, the pancreatic duct, either the main duct or one of its branches. That looks fine. But I think, as you might have guessed, this area looks awfully suspicious, right? The randomness, the angulation that you see in this gland, the random distribution, and the desmoplastic stromal response make this an invasive adenocarcinoma. In addition, there are these small glandular profiles that are icing on the cake. This is cancer, no doubt about it. And in addition, there are single cells. I love identifying single cells. That to me is one of the best features for a pancreatic adenocarcinoma. But if you look at the individual cells, architecturally, this looks obviously cancer. But if you look at the individual cells like that themselves, this doesn't look too bad, doesn't it? In fact, the cells look rather bland and monotonous. In retrospect, of course, everything looks like cancer, but I must say the monotony here is not helping me. It is the architecture that is very suggestive of cancer. And in fact, this architecture wasn't quite there on the frozen section. So let's take another quick look at the frozen section slide. So in retrospect, it was these glands that were all cancer. I'm not sure whether I could have called this cancer. Again, because of the lack of pleomorphism, I would be reluctant to call this cancer. If this were my case, I would have certainly called these glands atypical. But there is cancer on this slide, and it was staring at us in the face. And it is right here. Here's an arterial channel. Here's a venous channel. So this is a vein. This is intravascular invasion. And although this looks very monotonous, the mere presence of this cancer within the venous channel is diagnostic of cancer. You could argue that this is a push artifact, although given the amount of tumor in there, and given the absence of tumor in or the relative absence of tumor in the adjacent pancreas, suggests to me that this is not a push, that this is indeed true intravascular invasion. The resected pancreas, interestingly enough, showed extensive intravascular invasion.